Welcome, everybody. We've done some other of these webinars in the past, so I thought I'd better just quickly review the HRV basics. So the plan for today is just to kind of go very, very briefly through the protocol, mechanisms, and physiological outcomes of HRV biofeedback. Previously, we've discussed pain, GI issues, anxiety, basic HRV processes. Today, we're going to tackle three very different applications: essentially mediated pain syndromes like fibromyalgia, mild traumatic brain injury, and migraine briefly. So what we discussed previously is kind of a standard protocol for HRV biofeedback, where you're going to get 5 minutes of basic background data from your client using whatever device you're using. This is not limited to expensive devices. This could be done on any of the HeartMath devices, on the ones we're showing are the GP8 Physiocom Design, on Thought Technology, on the Nexus, or any other device. As long as you do that, what we say is that don't trust the proprietary software to do the analysis. Get Kubios HRV. It's free if you get the Kubios HRV Lite, and get a baseline for that person. And then we'll discuss a little later how you use that data. Once you've done that, we're going to try to determine what we call resonance frequency, which means that we're going to try and a bunch of different breath pacing, starting at 7 and working our down to 4.5, trying to determine the optimal breath rate for that person to practice that. We always want to say be very careful about people hyperventilating, because they often do. And if they hyperventilate, you'll lose them in the biofeedback. So if you have a capnometer, or just watch them closely, make sure they don't get lightheaded, dizzy, any of the hyperventilation syndromes. Once we get them going with a pacer, you'll get a screen, something like this. This one is nice because we have respiration, heart rate, temperature, skin conductance, and a spectral analysis. But you can get the spectral analysis on Kubios if you want to. And what we're doing is setting a pacer. They're following this little green ball, and what we're hoping for is patterns that look like this one, where there's a single peak at somewhere around their resonance frequency that relates to their temperature going up in their fingers and their skin conductance going down. If you don't have those other things, at least getting the peak in the resonance frequency range. Some clients will freak out when you do that, and they will have a tough time with the pacer. They kind of get competitive. We just give them this instruction: use your breath wave, try and maximize the heart rate wave as to get a big smooth waves with peaks and valleys. So you continue through the different peaks and try to determine the resonance frequency. Once you get that, you're ready to train the client. We usually print out a PDF, the Kubios summary, and go through it with the client. You get this just by saving the Kubios file. And then determining resonance frequency, we use highest low frequency spectral, highest internal coherence, respiration and heart rate and phase, highest average low frequency, highest peak to trough amplitude, smooth curve on the heart rate, and simple spectral peak with harmonics possible, as well as the soft signs would be skin conductance and temperature. So here you can see somebody kind of launching into this with the instructions, and you can see what happens to their heart rate. And in other webinars, we've explained exactly what's happening physiologically here that produces all these wonderful effects. So the softer signs would be like skin conductance going down and temperature going up. Then we send the patient home with instructions to practice at their resonance frequency. And then there's a whole variety of ways to having them practice at home. They can use our website, Music Free. There's that website for you if you want it, or just Google Gevirtz Wix site. You'll get our website, and you can download that music for free for pacing. And subsequent visits are checking to have the proper resonance frequency. They're getting a nice single peak. They're getting temperature going up, skin conductance going down. And then we train what we call rescue breathing or generalization, where we interrupt the client, and depending what the problem is, try to get them disrupted from their resonance frequency and then go back into it. And when the person's really mastered that, that's a tool we're going to use in almost all of our applications. That's what it looks like on the J&J system. Single peak, showed you that before. A number of different practice things you can use that are free. Breathe to Relax is free. Cardia Deep breathing is free. Lately, we've been finding some less expensive home devices. This Chinese company Kyto, Kyto, makes both a PPG and a polar strap ripoff that can be gone onto with Elite HRV. And you can actually do virtual heart rate variability biofeedback with these devices. The strap that they're now producing sometimes is as cheap as $15, and then everything else that comes with it is free. That was a incredibly brief overview of how to do HRV biofeedback, something we usually take at least an 8.5-hour workshop to do. So the first application is very different than anything we've done so far, are centrally mediated pain and fatigue syndromes. So these are called by various names. I believe that they all fit under some kind of a continuum. Fibromyalgia, chronic fatigue syndrome, myalgic encephalomyelitis is the term that the rheumatologists are now preferring because it sounds like a real disease. All of these are diseases that have no peripheral mechanisms associated with them at all. They all have to do with somehow the brain misinterpreting normal physiology and producing symptoms like fatigue and pain for them. These have been, especially with COVID, long COVID now, we're getting a lot of publicity for these disorders. And we're talking about a couple percent of the population, higher percentage in older adults, and a lot more news coverage of it. This is an article that just fairly recently came out, surveyed very large samples, and I think we're getting some pretty darn good data now about how prevalent these problems are. And this was before adding long COVID, but long COVID looks like it's another one of these disorders in the same vein. So these are people responding with either overall body pain or fatigue or both, with sleep issues, with mental fog issues, sometimes called fibrofog. Fibromyalgia, another version of this one, has gained popularity tremendously in terms of research. Used to be dismissed by the rheumatologists completely. Now there's a large number of people understanding it. You can see that very large numbers of research articles have emerged. So who gets fibromyalgia? Women get it 9 times more than men. There is a lot of comorbidity. People with abusive relationship history, early onset migraines. People get it sometimes as a result of accidents, other pain disorders, depressive disorders. People with Ehlers-Danlos, hypermobility are much more likely to get it. And it's very comorbid with PTSD. Also with repetitive activity, sometimes we see more of it. Often it starts with a chronic infection like hepatitis C or HIV. And there seems to be some sort of genetic familial predisposition, although we certainly haven't found a gene for it. The diagnosis has been controversial, but there are some new criteria for diagnosis now. They have pain locations throughout the body for fibromyalgia with symptom severity scores greater than 5. They've had these for more than 3 months. These are all the different areas of the body that we see the pain in. Fatigue is almost universal. Unrefreshing sleep, cognitive symptoms, often accompanied by headaches, pain or cramp, and depression. So people use these kind of body maps, and there's a number of different techniques. Sometimes they use an ergometer, a spring-loaded device, and they'll go ahead and push on these devices, and where it hurts all over the body is sort of used for the criteria. These tender points are not to be confused with trigger points. And the tender points are just kind of a loose way of finding out if the person has pretty widespread pain all over their body. People with fibromyalgia don't have any obvious pathology in the muscles or in the body. So normal body processes are being interpreted as pain throughout the body. This group at the University of Michigan has really done a great job of understanding this by using fMRI technology, and for us to understand it as a kind of a pain amplification syndrome or a touch amplification syndrome. Dan Claw being the kind of leading rheumatologist in this world. So we have evidence that aberrant central pain transmission from all different kinds of physiology. We know that these people are translating what should not be a pain into a painful stimulus. This isn't just that they're over-reporting symptoms. These are real pain processes in the brain. That means that very low thresholds produce pain, very low either mechanical or thermal thresholds. So you take a little black dot on the skin and heat it up very slowly. They feel pain much more quickly than on a healthy control. Mechanical, you have a little kind of a guillotine thing that you push on that produces pressure, and then that they tell you when that pressure first becomes pain. And when that happens, that you get a pain threshold from that. People with fibromyalgia have way lower thresholds, and their pain is summated across a wide variety of the body. They also have more substance P, which is a pain neurotransmitter. So we know that they're actually getting pain messages from those factors, even though there's no pathology in the tissue. There are also increased blood flow to the brain regions that are processing painful stimuli, not just the suffering of stimuli, the painful stimuli itself. So this is now being called a central sensitization or central augmentation, turning up the volume like an amplifier. And here's the kind of a device that's used with a little gauge on it. So you push down on something that would not be pain for a normal person, but for the person with fibromyalgia, they'll feel pain very quickly from the pressure of that device. And here's a slide that I use with every fibromyalgia patient. It shows that pressure from this device, the area of the brains that are lighting up are pain processing areas of the brain. When it's lighting up in red, that means that that is lighting up much sooner for fibromyalgia patients than it is for normal controls. So the yellow means that you'd have to a lot of pressure on the controls to get a painful stimulus. The red is very quickly you get this part of the brain lighting up at the same time they reporting feeling some pain in their hand. Equally painful, but not equal pressure. And that's the secret to do that. That's letting the patient know that you believe that their pain is real, even though all their medical doctors have told them there's nothing wrong with them. What about the autonomic nervous system for these folks? Well, many studies have shown that they have an autonomic dysfunction. They have a 24-hour dysfunction. They also just have low heart rate variability and poor reflexive autonomic nervous system. Here's some quotes from some experts in this field. Autonomic dysregulation may have implication regarding the symptomatology, physical and psychological aspects of health status. All right, let me stop and see if anybody has any questions about the etiology or the mechanisms of that disorder.
There is one question. It says, does this mean that we are increasing their pain threshold by doing biofeedback or addressing pain?
Yeah, that's what the goal is. So the goal is to actually return their body to something that has a normal pain threshold instead of a really low pain threshold. And that's what we're going to talk about next, is that the process for doing that. So we've encapsulated the treatment in this acronym called SABRE, because for fibromyalgia, you've got to tackle a much more integrated approach than just biofeedback. Biofeedback is always their favorite component. This approach really relies on a lot more stuff. So one of it is sleep. We do know that fibromyalgia patients have abnormal sleep. They have alpha spindles just when they're supposed to be getting deep wave sleep. They get alpha interruptions during that deep wave sleep. So they have a truly verified sleep disorder, which produces unrefreshing sleep. And unrefreshing sleep and low deep sleep also seems to be a prescription for lower pain thresholds in general for everybody. So the first thing to do is work really hard on sleep hygiene. All the things we know that are in sleep hygiene, I'm not going through in detail, but if you don't know what that is, it's go to bed, get up at the same time in the morning, darken the room, make it a cool room. There's really good material out there online for good sleep hygiene. With my patients, I give them a sleep log in the first part of the session. We go over their sleep for the week and kind of keep on encouraging them, because it's very hard to get people to do this. But once they actually change their sleep habits, that does make a difference. Next part is the part that we're talking about here, autonomic flexibility. That's HRV biofeedback, just what we discussed earlier. If they're involved in yoga, try to get them involved in a gentle yoga class. That seems to really complement the biofeedback. However, if they go to their YMCA or their gym and their yoga instructor is turning themselves into a pretzel, for these folks, they can't do that. It usually is counterproductive. Make sure they get somebody who will do very adaptive yoga with them. So the poses are very gentle, and it incorporates yoga breathing into all of the different poses. So just breathing retraining, aside from the biofeedback breathing, we want to make sure there's no sign of inner hyperventilation, that they're using their diaphragm for breathing. So we do spend a lot of time working on diaphragmatic breathing, hand in the chest, hand in the belly, but making sure that they can breathe without hyperventilation, both during the biofeedback, but in general, become much more aware of healthy breathing. Activity management is what the R stands for rest. So along with a sleep log, you give these people also an activity log. A typical patient like this was somebody who often was very active previously, and now they can't even do anything without taking a rest. However, they typically feel better and they start overdoing it. So you have to work on very carefully graded increased activity. Housework, walking, anything at all has to be carefully monitored and graded. Len Jason has a whole book on this called The Envelope Theory that you can look up and get much more detail on. And exercise is actually the most important component. I'd love to think that biofeedback was, but biofeedback is what they like the most. Exercise is very difficult. So you have to start with very basic exercise. The criteria is, does it make them better or does it make them worse? Anything that makes them worse has to be scaled back. They have to start with a very simple, even if they were an elite athlete before. I've been currently working with a professional triathlete, made her living as a triathlete, and had a bad injury and got chronic fatigue after that. And it's very hard for her to understand that just walking as exercise for her, and compared to the level of intensity that she was used to. But little by little, she worked her way back up to be able to run again, to be able to swim again, to be able to bike again. She's not going to ever be an elite athlete again, I don't think, but she's got her life back. She's got a job. She's got her relationships back, slowly working through with the biofeedback, with breathing retraining, with activity management, and with exercise. It's a slower process than other biofeedback modalities maybe, but it works.
I have a question. It doesn't include anything about eating habits. Do you take into account anything of that sort, or is it more just focusing on their sleep and their exercise?
We do encourage healthier eating, but there's so much to do already. It's hard for people to do it. So we kind of just encourage a little bit healthier diet, especially avoiding processed food, super processed foods. But the literature review hasn't been very supportive of dietary interventions for these things. Just in general, we all should be doing that, of course, and processed foods are kind of poison, but they don't have as direct an effect. So if the person is willing, we certainly try to direct them more towards healthy eating, but there's an awful lot that we're doing already, so it's really tough to do too much of that.
That's fair, because then it's essentially changing their entire lifestyle, which can be very daunting.
Right. If they're into that, but many of the people that we see already actually have tried a lot of dietary stuff that hasn't worked, and that's been promised to fix them, but it doesn't look like the literature supports diet alone was going to fix them, although it certainly is a good idea to get onto a healthy diet. So this is an article that another researcher and I published just looking at non-pharmacological treatment for fibromyalgia. The conclusions are basically that integrated lots of things seem to make the most difference for it. Here's a study that we did on supportive yoga, fibromyalgia, compared it to a cognitive behavioral therapy manualized treatment. And you can see compared to the control group didn't improve at all, of course. This is on overall fibromyalgia impacting their life. The CBT guys did improve, but just barely, but the yoga group really had a dramatic improvement. And in this yoga, we incorporated slow breathing. So, okay, fibromyalgia, very, very quick. I could spend a whole workshop on this, but the biofeedback part is just what we described for all the other HRV biofeedback. It's the part they like the most. You want to see their autonomic nervous system improving slowly over time, which it does if they practice regularly. So 10 minutes a day minimum, 20 is better. This is the part the patients like the most because it's the easiest for them to do. But we do see that mixture really works really well. And the pain thresholds do improve. So you do see them getting much less overall body pain. Something completely different now, mild traumatic brain injury. So mild traumatic brain injury, we're getting much more aware of it. It's in the publicity a lot more. Looks like about 5 million Americans are living with brain injury. That's probably an underreport. It's very common in athletic injuries these days. Severe brain injury is a different matter. So here we're talking about people who have concussive events of various kinds, from accidents or from head injuries in sports or other sources. And most of those people are fine, and 80% of the injuries are mild, but about 15 to 25% of those people move on to having more long-term symptoms. We just finished a study with the military because this is about the same percentage in the military, and the military is spending millions and millions of dollars trying to figure out how to deal with this, because many people get concussive events these days in military action. The pathophysiology is very complicated and not very well understood. Here's a review of the neuroimaging studies. Even though there's some hope with better and better MRIs or PET scans, the results are much more mixed, and we don't often see a clear-cut pathology coming from these injuries. So they're shearing injuries in the brain, and they're not easy to see on any kind of the scanning technology. Can we do somatic therapy and touch therapy and fibromyalgia? We missed that from before. Yeah, so any kind of somatic therapies are better than talk therapies alone. And if these folks are into it, then any kind of somatic therapy together with massage and things like that seem to be compatible, but they don't seem to give very long-lasting relief. So we think that SABRE routine, and if you want to include like weekly massages or somatic therapies into it, seems to give people temporary relief, and we encourage that. But there's not a lot of data that is successful with those central pain syndromes, because you're not really working on trigger points, you're working on central pain that we need to get at another way. In recent years, we've realized that there is a strong autonomic component to these disorders. A dysfunction of the autonomic nervous system is found to be a major factor in symptomatology of TBI, including mild TBI. The central autonomic network is a complex network in the central nervous system involving cerebral cortex, the insular, medial prefrontal cortical regions, amygdala, stria terminalis, hypothalamus, and brainstem centers. All of these are involved. We very regularly see a decrease in heart rate variability in the patients with mild traumatic brain injury. Here's an older review, but there is some more recent data too on it. So here's a good way of looking at it. It is also likely that the brain injury alters the fine balance between the sympathetic and parasympathetic arms of the autonomic nervous system, resulting in an imbalance of homeostatic mechanisms that maintain normal organ system function and their interactions with each other, as outlined in Figure 1 from a 2019 study. So here's a traumatic brain injury, some kind of concussive event. We got autonomic dysregulation being altered baroreflexes, sympathetic hyperactivity, impaired flow on autoregulation, elevated intracranial pressure sometimes produces inflammatory cytokines, and that's a cerebral vascular dysfunction, endothelial damage, which feeds back into the autonomic nervous system. We get altered not only sympathetic hyperactivity, but parasympathetic lowered activity. The heart itself, the cardiac output, regional brain flow, blood pressures feed back into that loop. And eventually there's even some kidney function that also feeds the same symptoms back around into the summary. So it's a very complex series of things that happens in these brain injuries. And we're focusing on one part of that, which is the autonomic imbalance. Very well documented, these patients have a neuropsychological function that's altered. So they suffer within months of injury, delayed memory, working memory, fluency, processing speed, attention, executive functions are most impacted. Patients that require more than 3 months of recovery often experience impairments in verbal learning, difficulty concentrating, deterioration of working memory. So these are pretty devastating injuries for people, starting with a fairly mild insult to the brain. These are not serious brain damage, but a mild one that still turns into a life-impairing process. So my student recently finished a study, which was actually done in Taipei, where we actually intervened with HRV biofeedback for one group of patients and with a psychoeducational intervention that's been used previously and has shown to be somewhat effective. So it wasn't really a placebo group, it was a control group that had been seen have some previous effect. However, in our study, I guess good for us, bad for the patients, the psychoeducation really had very little effect on these patients. So the results were very dramatically good. I think partially because the Taiwanese population were very compliant with the instructions, much better than Americans. Americans don't tend to practice as much as we want them to. Here you can see that these patients, you'll see the results were dramatic. So the first thing they did was they raised their HRVs. So these are kind of standard measures. Let's look at SSD. That's the most universal measure. Both groups started with about a 20 RMSSD. That's a pretty bad level. That should be about 50. And the control group never could really improve at all over the course of the treatment. The group that did the HRV biofeedback went up to 40, which is in the normal range. A little bit lower than we'd like, but in the normal range. That's a 51% improvement. Now, this is resting level RMSSDs. So these are sitting quietly, watching a video for 5 minutes before this treatment started. And then at the end of treatment, 5, 6 weeks, 7 weeks later, their resting RMSSD was back into the normal range. So that's very encouraging. Here's what each person's RMSSD looked like. You can see every single subject improved, some more than others. Within the control group, we had a couple of improvements, but very little, mostly. So very dramatic, 3 out of 21 versus everybody in the control in that group. How about their vagal tone? That's the LNHF. Well, again, control group don't change. Subjects in HRV group improved their vagal tone by 24%. I didn't put in the spider plots, but basically they look the same as the last one. Everybody improved here, and hardly anybody improved there. How about the neuropsych measures? So these are measures of neuropsychological function. Some of them are Taiwanese versions of them. Some of them are Taiwanese translations. Again, strong differences between the group in pretty much all of these measures. Here we have the frontal assessment battery, everybody improving, hardly anybody improving. Here we have trails B, lower is better. That's how fast you can do the trail. Control group, nobody improved. This is a executive function index. Biofeedback group, lower is better. The control group actually got a little bit worse. This is the PACE-SAT. That's a verbal processing neuropsych scale. Same results. There's the Trails A, verbal memory, same results. Verbal memory, another version of it. And even on the psychological scales, so these folks, only a few of them had clinical anxiety. So the cutoffs are around the teens. But look at every person except the person that had none improved. And here in the control group, only a few improved. And the same thing for the depression scale. They got much better. Even though they weren't depressed to start with, they still got better anyway. And irritability scales, the Taiwanese version of an irritability scale, same kind of results. So very dramatic findings. The biofeedback protocol was just the one I described to you by the book. Biofeedback, everybody practicing every day. Let's move on to one more application, migraine headache. So migraine headache is a universal problem. It's pretty much the same in almost all cultures and societies. It's been plaguing humans for 2 millennia. There's evidence of migraine in caveman drawings. At every continent, over 1 billion people have been attacked on any given year. Stands as the 6th most common cause of disability on the planet. And I'm sure all of us here know somebody. If we don't have migraines ourselves, we know somebody that does. It's a far less prevalent disorder than tension type headache. Tension type headache almost everybody gets, but there's almost no interest in tension type headache among the neurology community because it isn't really a neurological disorder. So tension type headache is pretty much a muscular problem, very, very effectively treated with trigger point releases and HRV biofeedback. However, 15% of the population does experience migraines, and migraines are more debilitating than tension headache for sure. So among the precipitating factors, stress is number one. Now, there are many precipitating factors for migraine, and it's quite unique to each individual. Some people get it from smelling a peanut. Some people get it from sunlight. Some people get it from, here in Southern California, we get Santa Ana as a weather condition. They get them. Fatigue, sleep, fasting. However, stress is the number one trigger. So we're kind of focusing on that. But we know that there are very strong autonomic components to migraine, and studies of migraine patients, kind of clever studies where they test the baroreflex. They found out the baroreflexes are much less sensitive in migraineurs than in non-migraineurs, even when they're not having a migraine. And they do that by stimulating the baroreflex. Also, a lot of studies showing high sympathetic function that we can see in the migraine population. Also, vagal nerve stimulation has been reported to abort migraines, so it's something similar to what we do with biofeedback. Julian Thayer's group did a very large meta-analysis on migraine and showed that vaguely mediated heart rate variability is reduced in patients with headache disorders in general, especially with migraine. And that's a fairly large or a moderate effect size. There are still more need for those kinds of studies because we think that might have an effect on their cardiovascular function in general. So the way we kind of deal with migraine with our patients is this cauldron model that I made up. The patients themselves know that there's a variety of triggers for their migraine. And so we kind of go through and get all the triggers and talk about them all. Since it's a 5-to-1 more female than male disorder, we talk a lot about menstrual cycle in females and whether that's related or not. It's kind of good if it is, because we then have a way of intervening at the right time of the month for the females, but it isn't always this case. The idea is that the nervous system is kind of this cauldron that's sitting there, not overflowing usually, but when you throw more things in, then it eventually overflows. And so combinations of stress and sleep deprivation, or stress and dietary, red wines or liquors, sunlight, diet, all kinds of things, if you add them in together, they can overflow and become a migraine headache. So what we try to do is do our best to kind of lower the triggers as best we can, but the one that we have some control over is stress. And what we know is what leads to a migraine is cortical hyperexcitability. We have very good fMRI studies on this. Unlike in other disorders, like in ADD, for instance, where there's underexcitability. And migraine, we know that the cortex becomes excitable and then it can spill over into the actual wave in the cortex that becomes an actual migraine. A migraine is kind of a thalamic, sort of a seizure type phenomena that actually becomes a migraine. So the things we can target are good sleep hygiene, just as we heard earlier. Diet is important, especially caffeine management is really important. So diet, there are a number of foods that are vasoactive, and the migraineurs usually kind of know that, and we kind of talk about that a little bit. Usually if they come to us, they already figured that out. Relaxation approaches of various kinds, but especially HRV biofeedback seems to be a real good targeted for their anxiety and stress. In addition, if they're interested, we can do a little bit of empirically based psychotherapy, either cognitive behavioral therapy or ACT. Both have been shown to reduce migraines somewhat, just by kind of reducing stress probably. And in addition, the HRV biofeedback is useful in coping with the pain of the migraine itself. Doesn't take it away, but it is helpful in coping with it. So clinical trials and studies have provided evidence that these behavioral interventions, especially when they're coupled with pharmacological treatments, really do improve migraine. It's a famous study by Ken Holroyd that did a placebo reduction in migraines over 30 days, a beta blocker, which is an effective, but look at just barely better than placebo. Placebo and behavior was a little about the same, but when you put beta blocker and behavior together, that produced a really good reduction in migraine. 5 migraines on a 30-day over a 10-month period reduction. So there is pretty good evidence summarized by this that combinations of behavioral and whatever pharmacological intervention there is seem to be kind of useful. There are a couple of more recent studies using HRV with home devices, like app-based HRV was found to be feasible and helped a bit with migraines. This one was a real-time assessment of effective biofeedback therapy with migraine. A pilot study, computerized, showed that biofeedback could improve the symptoms of migraine, including psychological stress and headache-related disability. That's a 2015 study. In our clinic, we do have some experience with migraine. It definitely brings people in if the medicines aren't working very well. There are a whole new spate of new, more effective medicines for migraine, but they're very expensive and hard to get prescribed. It's very tough to get them because the insurance companies don't want to pay the money. They're very expensive. However, if they can get on one of those new blockers, that seems to be quite effective in blocking the pain of migraine. Anyway, what we found is that you do the HRV biofeedback combined with some talk therapy with sleep hygiene, and you get those people practicing regularly, we get pretty dramatic drops in migraine. We do myofascial release sometimes is effective in treating a tension headache or mixed headache for those. And so I think our track record in our clinic is very good. We never cure migraine, hardly ever, but sometimes we can get down from 4 a month to 1 every 2 months. So we consider that a pretty good success. So in summary, breathe with your heart, don't ruminate, resonate.
That's
All
super
right,
funny.
so we've got a few minutes left for general questions, comments.
I did have one question. I guess it's more popular for people to just hear about HRV and want to buy like a device and do it at home without any proper training. What are the benefits or limitations of that, do you think?
Yeah, it's only anecdotal evidence, but we keep on hearing people buying devices and trying them and then putting them in the drawer. So even when we do it with them, it's still hard to get them to practice with it. But now there are fairly inexpensive devices, and I think what we're hoping for is to combine that home practice device with in-clinic treatment and maybe cut down the number of sessions people have to come in, but still get good treatment using the devices that are out there. And we're doing more and more of that now.
Yes, thank you. It makes these treatments more accessible to more people if they don't have to spend extra money to come in for more sessions and can practice at home. But I definitely do feel like there needs to be the educational portion where you go into a session and they explain all of the things that they're supposed to be looking for, rather than just following an app, which might go in depth, but might not.
Yeah, I totally agree. I would think it's worth spending the money at least for one good session, maybe the session to get your resonance frequency and some instruction, even if you want to do the practice on your own after that. However, as you can see from the mild traumatic brain injury data, practice makes perfect here. People who really practice had amazingly good results. We attribute that to the wonderful nature of the Taiwanese people doing what they're supposed to do it, because we don't see those kind of results in American samples.
That's definitely fair. What have you experienced or learned that kind of encourages people to continue with their practice rather than just like doing it once and never coming back to it?
Well, we use motivational interviewing techniques. If it's kids, we get the parents to do a token economy. We don't allow them on their video unless they practice. Give them treats, give them money, even for kids. For adults, we work with them to try and work out a way in which the practice is going to make sense. Where are they going to do it? How are they going to do it? What time of day was going to work for them? Are they going to use an auditory pacer? Sometimes auditory pacers increases compliance because they can do it on the bus or on the train or in the Uber. You can just put the music on and do it. Remember, I gave you the website with our music that's free to use for them. So it's kind of trying everything and anything to get people to practice.
It's like building a new habit, and that's always difficult to get people to do. Mhm.
Absolutely.
Thank you, Dr. Giverts, for being here today. We truly appreciate all the work and your presentations that you provide us. It's a lot of good information and it makes it very accessible. So thank you again, everyone, for attending, and we'll see you guys next time.